Hi, Deb.
You can't hear me. Hey there.
I can now. How are you?
I can't hear you.
You can't?
Oh, wait, but that's because my headphones aren't plugged in. Oh, I miss Broadway. I thought we'd have something viral to kick us off. Welcome to the AAP Spring Conference Series. Thank you for joining us. I'm Deb Hagler, the chapter president, and I'm going to kick us off. We have a few housekeeping things. If you are claiming CME, you will get an email probably tomorrow to do that administrative task. And I just want to remind you, there is more coming, lots of great things. We're going to talk more next week. You probably get tired of me, so we'll rearrange pediatricians at the helm of this. And we are recording this, so by joining us, you are agreeing to be recorded. And I will say thank you once again to Dee for working her magic and organizing all of this for us. And I am then going to go on with this evening's talk. And thank you to Dr. Amanda Goddard, who is going to update us on some things and review some of the basics of COVID. We have come a long way in a year, but I think that this is a tricky virus and we've got more clearly to learn. Dr. Goddard received her medical degree from the University of Massachusetts Medical School and did her residency at the University of Connecticut Children's Medical Center. She did a fellowship in pediatric infectious disease at the University of Washington, Seattle Children's Hospital. Dr. Goddard is an assistant professor at Tufts University School of Medicine and is a pediatric subspecialist in infectious disease at the Barbara Bush Children's Hospital. She is currently working on a multi-center study to describe the epidemiology, clinical presentation, and outcomes for pediatric patients across the country who have COVID-19. Over the past year, she has taken up the hobby of gardening and continues to enjoy spending time outdoors with her husband, son, and dog. And though she finds it a challenge to train her dog not to chase squirrels, she has had some success with cucumbers. Those dogs are going to all have trouble when we are all permanently out of our house and on some kind of normal schedule again. Thank you, Dr. Goddard, for joining us tonight, and I'm going to hand it over to you.
All right, thanks for having me tonight. So this is part one. You'll be hearing from me a little bit later in the month on a small series on sort of infection control and in the considerations in the era of COVID-19. I have no relevant financial disclosures. I don't really intend to discuss any unapproved products. And I will disclose that most of these slides came from a set that looked like that Dee had forwarded me through the AAP, Project ECHO for infection control, and also through CDC's Project First Line, which I'll explain a little bit. This series was sort of the impetus for this was Project First Line, which is a national collaborative led by the CDC in the US to provide infection control training and education to frontline healthcare personnel. And they have a partnership with the AAP. And anything I say, though, is not supposed to be necessarily represent the policies of the CDC. So I've added a few slides in here as well. And the things I say aren't necessarily representative. And this is just the website for the CDC for Project First Line. I think some of these videos have been getting put up on the main AAP Facebook page. There's 16 videos. They're small, 3 to 5 minutes. I've been sort of watching some of them as time goes on. And different things like episode 9, what is personal protective equipment? Why is eye protection recommended for COVID-19? The one that was like number 16, I didn't really know the difference between sort of cleaning and disinfecting. Actually, I was like, oh, I wonder what this is going to say. So some of these have been pretty good to watch. I don't think I've done all 16 yet, but I've been slowly watching them. The objectives today are to understand how COVID-19 is transmitted. And I think as the year has gone on, we have learned more and have a little bit better understanding than we did a year ago. And understanding in the context of infection control, why some of the things we've been doing over the past year, why we've been doing them. And infection control, everyone's sort of used to that. We've been doing these things for flu, for RSV, for when you're in the hospital setting, Clostridium difficile. So the concepts aren't necessarily new, but thinking about why we're doing some of these for COVID-19. And so what we know, I think we know a little more than this, but two of the main things that we know that we didn't know a year ago is that it is mostly SARS-CoV-2, which causes COVID-19, is spread through close interactions with individuals. It's considered still more droplet spread, but there is a continuum between droplet and aerosol, which you'll see sort of in the news a fair amount. And that we know being within about 6 feet of someone or sharing a poorly ventilated space with someone or people who have COVID-19 or with an infected individual for an extended period of time increases that risk of transmission. And what we really didn't know a year ago or appreciate was this asymptomatic spread and pre-symptomatic and how many people can be asymptomatic, and that happens more actually at younger ages. Those are some things we didn't know a year ago, and that it can really be spread before someone shows signs of symptoms. So this is something where the day before you're sick, even feel sick, you can be spreading it, and that affects infection control, where you can't just say stay home. It's possible you are spreading it the day before, which is why we're masking. Mainly spread from person to person through secretions, through our coughs, our sneezes, our talking, our laughing, our singing, and getting into the eyes, nose, and mouth of people nearby for them to inhale and get infected. We've seen pictures like this. Our droplets don't necessarily spread this far. This is, a cough sneeze. This isn't how far most of us spread our droplets when we're talking, but this just gives you an idea of how far these can spread. And this is just our droplets. There's not necessarily virus, doesn't necessarily go that far, but can be in some of those droplets. This is a video. Basically, this video I found a year ago, but I still like it. So I was gonna bear with me. I was gonna play it. It's not very long. It just helps sort of visualize, like when we're talking. This is just showing sort of air movement, and just with regular talking, we are kind of exhaling out. I liked this in the wintertime, actually. There's not many studies in kids with these type of looking to see how far things go. And definitely sneezing is more. So this winter, I was doing a lot with my son, having us breathe out when we go outside in the wintertime, seeing that cold flow. Who can get that cold flow to go further? Whose breath goes further? His breath, my breath, or my husband's breath, depending on what we're doing. So the lack of knowledge of how far kids can spread droplets was fun to test this winter time when it's cold out, because that's when you see the drops. And we see a lot of people with that mask under the nose. You definitely are spreading with that mask under the nose. And this is, when you have a mask that's good fitting, it does less. So the ideal is that mask down in the bottom right rather than a loose fitting mask. Still going, rather than the mask under the nose. And then our speech particles are kind of heterogeneous. There are some studies, again, this is more in adults, looking at down on the right, if I breathe through my nose, and this is just particles, I send out less particles to the world. I have allergies, so I'm a mouth breather at baseline. So I'm spreading a little more, but not much more than the nose breather. But then this study looked at if you breathe deep and then fast, how far it will go. If you go fast, then deep. If you talk quietly versus, middle. If you're loud, how far does that spread? And it's kind of intuitive, right? If I'm screaming, singing, I'm going to be spreading those further. If my son at the time, really, I've gotten to stop roaring actually, but it's been a process. He loves to roar like a dinosaur. And so telling him he can't go do that up into strangers anymore, and the kids in the neighborhood. And so definitely breathing through your nose is best. And so our particles will spread further, but that's sort of intuitive as well. But the study kind of showed that. And then we also saw that kind of early on, like Deb was saying in the beginning, she'd love to go to Broadway again. I know New York kind of in November to December time, I used to love going there. And haven't done that, but recently, but this choir practice was sort of early on in the time of COVID, where there was one person, this little red dot here, where they had a choir practice with one person assumed to be infected because they had cold-like symptoms beforehand. And 53 out of 61 people at that 2.5-hour choir practice were infected. They weren't all, the chairs were close, like 6 to 10 inches apart, but that one person obviously probably wasn't next to everyone that whole time. And they did have some empty seats because only half of the people that normally attended. And there was the complicating fact that there were snacks as well. So there was eating and singing. And so definitely early on this, from the CDC, avoid groups, try to stay 6 feet apart, and try to wear your face coverings. And then for this is more like for the office setting though, there also is some studies, one study that showed it was in a restaurant where there was one person infected and there were people far away from that person that also got infected. And they were looking at kind of thinking it was an air current in a poorly ventilated space that contributed to that. And this is something early on, a lot of people were doing, what is your HVAC system like? I never really talked much about HVAC systems until last spring. How many exchanges of air do you have? And, having colleagues and friends that are in these small office buildings and smaller practices, a lot of times you don't really have control over that older buildings HVAC system. In the hospital, I could find that information out easily. When I was talking with friends, it was harder for them to figure out from their building, what's that HVAC system like? And there is standards of care for air exchanges in clinical spaces, and that link to the CDC is on there, and that you could consider auxiliary HEPA filtration. If not, there are some specifics that some people would think if you bought a HEPA filter, if I get a filter that filters the most but doesn't quite fit as well with that system, sometimes that actually can be worse. So there's definitely a science to HVAC that I still don't 100% know all the details of, but definitely something that in last spring and over the summer, thinking about your office space and how it's ventilated. And then, the infection control guidelines for COVID say try to avoid aerosol generating procedures if possible. I don't think anyone's really doing those unless you need to. But in those situations where you are, those are the times you might want to definitely have your PPE available. And those procedures in some places ideally should be performed in a negative pressure room with only essential staff present, but not every office has negative pressure. But the idea that if you're doing something aerosol generating, to have as few people in the room as possible as well. And talking with people when they're doing nebulizers in the office, trying to have as few people in there as possible, or have the parent hold the nebulizer and you actually step out of the room. And so all these things you didn't necessarily have to think about before. Now, data is really limited because what's an aerosol generating procedure? Data is limited regarding which procedures in healthcare setting are the most aerosol generating. And some people have thought maybe if you look, I just have the one arrow under this list on the left that's considered aerosol generating, that standard nebulized treatments have been for a lot of people that put these lists together, put on the side that's aerosol generating, but it's really uncertain because we see an aerosol when we're giving a neb, but is that just the medicine? How much does that then make my airways aerosols? So that's really unknown, but that does get often put in a procedure considered aerosol generating. And our NP swabs are considered aerosol generating, where a throat swab, a regular oral pharyngeal swab, isn't considered aerosol generating for things we would do in the office that are kind of on the right. Dental surgery is considered aerosol generating. Dental cleaning and other routine dental work kind of gets put on the non-aerosol, but sometimes when I've been in the dentist, they're avoiding doing some of those deep like cleanings where they use the vibrating kind of cleaning because those probably are a little bit aerosol generating. And so when you think about infection control methods, we know this, it's to protect people from infectious diseases. And definitely we wanted to protect the healthcare workers, people in our offices from COVID-19. And thinking of preventing exposure is especially important early on, right? In the spring. I mean, it's still important now. We're just getting vaccines up and going, but especially important when we didn't know there's vaccines coming, when we don't, still the outpatient treatments isn't like you can just take a pill. It's not like you can take something easily. Hopefully that'll come where now you need infusions really for preventative treatments. And each component sort of builds on the next in sort of looking at source control. That's trying to keep infected people, less infected people, possibly infected people in the office setting, visitor exclusion, screening and triage practices, environmental hand hygiene, personal protective equipment. And those are all things every office has been having to think about in the beginning and then try new things because some of the practices we didn't necessarily work for the office that you thought was going to work, especially with like crowding and screening patients. Source control really being practiced by everyone in the healthcare facility. I wear a mask, you should wear a mask, remember to mask. Initially what we were doing is sort of concentrating on masking more in patient care areas. And now we're sort of masking everywhere. You come into the office and the mask goes on, and the only time it's not on is if I have a room closed and no one's near me. And then sort of being cognizant of break rooms early on, there have been some healthcare transmissions associated with break rooms. And so when you take down that mask, especially trying to be 6 feet apart, because in the healthcare setting, a lot of times we can't be 6 feet apart. You can't be 6 feet from your patient. You can't be 6 feet from your colleague who's helping you. But when your mask is down, trying to be 6 feet apart in less crowded rooms. Cloth masks being worn by patients and visitors, and some people are also using medical masks when people come into offices in healthcare settings, or when you go into Home Depot. Sometimes if you don't have your mask, you're given a medical sort of a disposable mask, but ideally everyone should be masked. I don't know, you guys can tell me, I have been hearing more and experiencing more over the past month as COVID fatigue seems to be getting worse. More people yelling at me about when I'm asking them to wear a mask, which I'm surprised about. I feel like that's been happening to me more in the past month than it happened to me 6 months ago. And I feel that could be the COVID fatigue or it just happened to be some bad interactions. But asking patients and visitors to mask. And that does get complicated with the young ones because it's harder for them to mask. But I have been greatly surprised at some of the kids in the office that are masking, these little active 3-year-olds keeping their masks on, which I've been pleasantly surprised actually by and impressed with actually. And then we're wearing, healthcare personnel are wearing surgical masks at work and then switching to respirators, either N95s, depending if your hospital, some hospital settings have PAPRs or cappers is another term when you have the kind of head on and it's using positive kind of flow when caring for known or suspected COVID patients. And I think the harder thing on the pediatric side too is kind of limiting parents and guardians, limiting siblings too, when you have a parent that has 3 other kids and how are they going to get to that appointment? And so I think that adds an extra complexity to the pediatric source control side and in adults with disabilities too. I mean, often you need to have someone with you. How many people are you going to allow is something every office needed to kind of figure out during this time, every healthcare setting. Well, how many people can we have in our waiting room? How many people can be in the exam rooms? And everyone has to make exceptions too, I think, for some things. And then the triage and screening, it's definitely something every office has had to think about. in the beginning, who's appropriate for telehealth, who isn't appropriate for telehealth, and, coming up with your list of what will that look like, what to expect for the people when they arrive, telling them ahead of time it's going to be expected that you mask, telling people ahead of time when you arrive, you're going to be in your car, you're going to wait in your car, I'm going to call you in your car when it's time to come in. And so every office has something different with that as well. And then telling them who's allowed to come with them. You're allowed one person, you're allowed two people, who's allowed to come with the patient. And then I think, most offices already pediatric offices are used to kind of the coughs and colds in the wintertime. So the hand sanitizer, the tissues, the barrels, I think a lot of us already had those in the office. And then this was a hard one, at least in my office, like the limiting and monitoring points of entry. So we had the screening down on the first floor, and at one point it was causing clusters of people. So when you go down there, you're like, you really don't want that many people clustered together because it's cold out and they can't kind of wait outside the door, and kind of thinking of different things for that. And clustering in the elevators is the other thing. And I've found really helpful. I like visual things. So I love in the grocery store that there's arrows on the ground. And at one point, Hannaford got rid of them. And I was like, I don't know which way to go. I was upset. Where did my arrows go? And the circles to stand on, those visual things. I noticed once those got put in some elevators, you would have people come in the elevator, look up, and then go, oh, I'm going to go over to my circle. Like that, having that visual, those visuals, I think really do help people of where to go and how to space, where if you don't have those visuals, at least for me, I sometimes still crowd into people because when I talk to people, I like to get close to them and finding, I need to get back. And then the having the patients wait in the car, right? That's hard in Maine. It's cold in the wintertime. I was still, having people I know in small practices, if someone had fever and it's a 2-year-old, but they needed to look in the ears, crawling into the car to look in those ears because that kid couldn't come into the office because of the fever, and trying to think about mechanisms for that, and things you're going to wear to work when you're going to be climbing in and out of cars to look at sick kids. I know some offices have had it where they're able to put one whole office as sort of their pediatric respiratory center, but a lot of offices had to kind of troubleshoot of where they're going to see these kids. And early on, I know some I didn't hear as much in Maine, but in some other states, sending the kids all to the local urgent care, which also isn't necessarily the best thing either for your medical home, sending these kids away from your office. And then again, we all get screened. Screening ourselves, screening everyone that comes into the office. Sometimes it's happening on the phone. And then also once they get to the office as well, and thinking about what do you do when someone screens positive? What do you do when someone calls with a concerning symptom for COVID? And yeah, like we just said, where are they going to be seen? Thinking about where you're going to see them in the office. And then when you're having your well child care follow-ups for, non-infectious reasons, and they happen to screen positive, do you reschedule them? Are they a candidate for telehealth? And kind of thinking about the flow with that. And if they had COVID or their symptoms are concerning for COVID, ideally, you don't want to see them in the office for 10 days. If they have an exposure for someone with COVID, still in the healthcare setting, the CDC is still saying, because it's more of a high risk area, that it shouldn't be for 14 days that you're coming in if you're exposed. It's like, it's really confusing for families. I was told my quarantine is 10 days. In other states, I was told my quarantine is 7 days with a negative test. But why are you telling me I can't come for 14 days? And I think some people are still pretty confused by that. But in the healthcare setting, the quarantine is still recommended to be 14 days from the exposure to come into the office. And then we're screening everyone again. And what do you do when that person who gets into your office then screens positive, where they're in your exam room for something else, and you see the nose running and they start coughing? What are you going to do with them? How long are you going to close that exam room for after that person was in there? And so all these kind of plans, we used to have to think about that for chicken pox. But again, that's not seen as often. So how long do you have to close your exam room if a kid was just in there that you're worried had COVID? And so it depends on the air exchanges you have. So if you have the lowest amount of air exchanges, it can be 2 hours that you're supposed to close that room. If they were coughing a lot and you were worried they didn't wear their masks or making a lot of aerosols, but if they were wearing their mask and you just took it down and noticed that, really you don't have to close the room for that long. And then just making visual alerts for your masking, your hand hygiene, your distancing. And then easy access to that, which I think a lot of our offices already had the easy access to hand hygiene. The masks are something new that if someone shows up without a mask, you have to have a mask. And I know some offices even had, for the little ones under 2 that couldn't mask, I know some offices had these cute little face shields that look like animal patterns on them. I don't know where people were getting those, but I have seen those in some offices. And environmental hygiene was a big thing in the beginning. Like, I am going to take my mail and make it sit for 3 days. Like library books, when they were returned, they were like quarantining packages in, because we didn't know how much this was on surfaces. Surface spread does not seem to be the primary. There's still always the possibility if I gave a good achoo on something and my wet secretions got on there, and then someone else came and touched that piece of mail and then touched their eyes, that they could spread it, but that's not the primary mode of spread. And for environmental, you don't need anything different than what's already being used. The SARS-CoV virus has a lipid layer. It is that's readily damaged by regular soap disinfection. So all the regular disinfection practices we used in the office are fine for that. All the wipes that were normally used for flu, RSV are fine for SARS-CoV-2. And again, for environmental hygiene, checking your HVAC system, your airflow. There's not great evidence about the physical barriers, like using the plexiglass and things like that, but intuitively it still makes sense to me, especially your people that are screening to try to help. It kind of puts a barrier to keep them away from people. Some people at some of our front desks will have plexiglass barriers as well. The grocery stores had them. There's not great evidence, but it makes sense to me that it's additive to have that there as well in some situations. And then the next part is, we heard a lot about in the springtime of last year is our personal protective equipment. The news would be saying PPE all the time. I feel like the general public, people I know not in medicine, knew what PPE was, where really, it would only be in healthcare you knew. And people would be like, hey, how's your PPE? And I was like, how do you even know about this? It was on the news all the time. And still shows up on the news sometimes, but not as much as in the spring. And kind of just reviewing, I find it helpful. It was more during Ebola time where I really was reviewing donning and doffing and realized that I'm sort of lazy and don't always take things off correctly. And this was really hammered in during the time when Ebola, hospitals were practicing their infection control methods, and we would throw some chocolate on some gowns and see if you spread it anywhere, that kind of thing. And even at the beginning of this, having my colleagues, we all watch each other practice it once, see if you're donning and doffing correctly, putting it on and taking it off. And then do we have the right things in our office to see someone who actually has COVID-19 or where they're going to be seen, you do N95s, peppers, eye protection. I will tell you that even seeing kids with flu in the past, I haven't been as diligent about my eye protection. If I couldn't find the goggles, I'd still go in and examine a kid and I wouldn't try that hard to get my goggles. But eye protection really should have been part of even more seeing kids with the flu, but how many offices was that something you routinely did? Sometimes there's the masks that have it on it. But really COVID kind of hit home to me of how important that is. I got my mouth covered, but if someone coughs in my eyes, that's a risk. So I want my eyes covered either with goggles or face shield. And being, if they're reusable, you got to wash them and disinfect those the correct way. And then the gowns that are protect our clothing throughout the day, and sort of if same thing, especially 2-year-olds, they're often getting a lot of goo on you, so kind of protecting you and protecting your clothing in that way. And then gloves, really just to make sure the material, it's easier to kind of make sure that we should be doing hand hygiene. So do we really need to wear gloves? But gloves kind of provide that added level of protection in addition to hand hygiene. And again, the practicing, in the slide set, talking about how PPE only works best if you use it correctly every time. And it, sometimes the mask falls down, the goggles fall down, wearing an N95 for a long time, that seal, making sure that seal's good before you even go in the room. And then you want to make sure where you're working has adequate training and practices to help you practice for that donning and doffing in your infection control policies. And then reviewing, I put the link down here. There's a video of correct donning and doffing. So that's down there if anyone wants to look at it. I don't know if any offices did their practices of having, let's watch me how I take this off. I do, I like visuals. And so this is what the CDC says is the, preferred PPE. If you're taking care of a patient with COVID-19 and you're a healthcare personnel, ideally, they still are recommending an N95. And a lot of people still say to me, well, if it's droplet spread, why are we still wearing N95s? And there is just, especially in the healthcare setting, you're having people cough. If they're coming to your office, it's often because they're sick. You might be doing something to them where you could do an aerosol generating procedure. And we're not immune to this. It's a novel virus to us. And so easier for us to get infected. And so that's why N95s are still listed as the preferred PPE. An acceptable alternative, which I know some hospitals were using in the springtime last year, is wearing a face mask, a medical grade face mask, with goggles or a face shield, wearing their gowns and gloves. And this is just the CDC. There's a lot of words on here about how to, for donning and doffing and the sequence you want to do it so then you don't touch your face and contaminate you or contaminate your environment, and making sure you're all clean for which way to go to, you want to put your gown on, your respirator on, your goggles and your gloves. And then how also to remove them. Ideally, your gloves and your gown kind of come off. Sometimes together if it's a disposable gown. If it's not a disposable gown, often taking your gloves off first, then going to your goggles and then your gown. But this has a lot of words. I do like, each office was doing something different. I like pictures. And so these are the ones that are at least here in the hospital. I was looking at it the other day as I was doffing it. At least it seems like the COVID cases are coming in cycles in kids. And so I will go a month without having to see a kid with coronavirus. And then all of a sudden I'm seeing 2 in a week. And it sort of goes again with the peaks in our community that I end up seeing some kids. And the other day I was seeing a kid and this doffing sign was there. And I just liked it because it has sort of things you're using in your setting. Like we use paper bags to put our masks into. We have these other plastic receptacles. So this was more applicable just to our setting, which I think is nice if in individual offices, what the supplies you have, having those in picture format is helpful. It at least helps me because I'm a little bit more visual. I'm like, oh, when do I put this in my paper bag? How do I do this? And so I still look at this sometimes. And I just did it a week ago. And then I was thinking a lot about a year ago. So what was going on a year ago as I was making this talk? And wow, a lot has changed in a year. Our knowledge has definitely changed. Our access to things, the angst, like a year ago, the the brewers in Maine were making us hand sanitizer, right? Like they were hand sanitizer, you couldn't find it. And there was even worries in the healthcare setting, we weren't going to have enough of it. You definitely couldn't find it for personal use. And so the breweries, Allagash Brewery a year ago, that they were making hand sanitizer and any extra masks they had. He has a box of N95s. I don't know as much about brewing, but I guess you need them for brewing. They were donating. Everyone was donating masks, and they also were making hand sanitizer for us. I also, thinking back, some governors, this is the governor of Massachusetts, basically getting thanking a sports team for taking their plane to get N95s, going overseas to like pick up N95s. It's just sort of wild to me that was a year ago. And we also in Maine have a company, Puritan, that's making nose swabs, and they were making millions of them, having their workers work overtime so we could have enough swabs again last spring. Like sometimes I'd get a kit to do a swab, and it'd just be a different swab I'd never seen before, and I couldn't break it off. Why can't I break? Oh, it's a different swab. The other ones must be on shortage. And talking about last year, talking a lot about PPE reuse, extending them and thinking about what you're going to do in your own office for, are you going to wear that N95? How many days are you going to wear that N95? How many patients? What's safe to do that? How long are you going to wear your face mask? A lot of offices had disposable gowns, and those went on shortage. So can you get the ones that you need to launder? Gloves, even at one point, were sort of going on shortage. So should we stop wearing gloves for kids with MRSA? Other things that you don't necessarily need to wear. Can we not wear gloves for other things? And so, the CDC sort of was putting out guidance for if you're caring for an asymptomatic patient, you don't know that they have COVID, that, we should be wearing our medical masks, eye protection. If you're wearing a gown, use it all day if it's not soiled. Really, I think most of us are using our masks all day and our eye protection. Gowns are more for if someone else can't mask or they have something where you need to wear a gown for. And ideally, though, if you use gloves, those should be obviously changed between patients. And then if you're caring for a patient with a COVID compatible illness, so you get your febrile kid coming in, to think about, you want to get rid of that between patients. But your eye protection, you can sanitize between patients. So it's a different thing than in the hospital. If you have one whole unit with just patients with coronavirus, there is some guidance that you could keep your N95 on for a whole shift and just go room to room, just to the patients that have coronavirus, and keep your shield on and go room to room, obviously just kind of washing your hands in between. And then when you're performing an aerosol generating procedure, again, thinking about wearing your highest level of PPE, and deciding, do you need to reuse it or not? And in some states, I think Massachusetts was one of them, there's these different mechanisms. Some states were using UV light to kind of sanitize their N95s. There's another hydrogen peroxide system where hospitals basically were saving all their N95s, sending them to get a hydrogen peroxide mist, and then getting them back. And there are definitely times during this that, people were saving N95s in case that needed to be done. And the CDC had some things, strategies for optimizing your supply of PPE. When thinking about this again, you did have to think about it again during that time that we're peaking up again, kind of this winter. And do you need to think about, if we're using a lot of our PPE, well, how do we conserve that? And there are things on the CDC site to help you to look at your utilization rate. When you make changes that you want personnel to kind of, when we went to wearing a mask, your surgical mask all day, telling people how to take it off to eat lunch, where you should ideally put it. So training needed to go with that too. And kind of going from your green, your yellow to your red, where green is what we normally do. Yellow is what you do when you anticipate there might be a shortage, and crisis when there actually is a shortage. And some of the things that were done more last spring, right? Like people were canceling elective and non-urgent procedures and appointments for which PPEs typically use. So that's in the crisis of that, basically all elective and non-urgent surgical procedures were getting canceled. Dental offices weren't seeing patients last spring. There was this conservation effort for PPE. And in the beginning of the COVID pandemic, obviously you're going to keep people in the hospital if they need to be in the hospital, but trying to get stable patients home when they met that criteria. In the beginning, when we didn't know as much about coronavirus and COVID-19, sometimes people's length of stay was longer. And so kind of working to get people to get home earlier as well and get out of the hospital to decrease the length of stay. For your N95s, a lot of hospitals do annual fit testing. So, you do fit testing for the people that need it, but maybe hold off on the annual fit testing where everyone's coming in to get it done if they've already been fit tested kind of in the year prior, and then extending the use of N95s. And then when you get to crisis capacity, we're talking about reusing those N95s, and some of those systems to clean them could be, you get 4 uses out of an N95 as well. And then our face masks, I thought, in the beginning, they were all locked up. Now I know the code of how to get my face mask, but sort of locking up face masks because they were disappearing outside of some of the clinics. Pre-COVID, there'd be a box of face masks, a box of tissues, and some hand sanitizer kind of out in the hallway. And those were disappearing. And so actually all those things had to kind of get taken inside. And then providing face masks to people at checkpoints, or if it gets to crisis capacity, really restricting face mask use just to healthcare providers and asking the patients to kind of just to wear their cloth face coverings, which now in the beginning, not everyone had cloth face coverings, but now I feel like most people have them as well. And if you run out of masks, there was this option in the crisis management to really just use face shields if you had no access to masks. Still talking about, I think that was last March, April, where there was guidance. Yeah, if you don't have masks, wear in the healthcare setting, wear a bandana or a cloth face covering. There were people sewing. I think LL Bean was making masks to give to us at one point in time. And to kind of wear your cloth face mask with a shield. And a lot of companies were making shields too. And then this is just, if you're thinking about your PPE, I think everyone's already gone through this though, of the link to your burn rate calculator and a tracking app that can you can put things in to track the PPE in your office. And hand hygiene is always, that we're doing hand hygiene with alcohol hand sanitizer, that doesn't seem to be as a shortage anymore. And washing your hands with soap and water, those are both effective ways to eliminate SARS-CoV-2 if it happened to be on your hands. And then again, detergents like soap and water and alcohol-based hand sanitizer do both kill that virus. And sort of looking, as doing this talk, I saw, everyone has been telling me when I talk to people on the phone, you've seen no flu this year. And, looking at the flu view, there's hardly any flu in the US, but this study just came out last month online in the Journal of Hospital Medicine, where, looking at 44 children's hospitals discharges from the ED and inpatient units, pre-COVID, early COVID, and in COVID, and seeing that their hospitalizations for respiratory illnesses are down by 62%. RSV, I don't think we've had a positive in the hospital, and there's been 1 or 2 kids with bronchiolitis that I've heard about, but it's just amazing what we're not seeing because of the masking. And that raised this Kaiser Health News to say, should we be doing masks forever? Like, should kids in daycare keep wearing masks? I don't think we're out of COVID-19 yet, but in 2 years down the line, would it be nice to kind of keep these things at a lower rate? But again, it's probably good for our immune system to get some viruses sometimes. So there's always that balance of that. And then just looking at the influenza-associated pediatric deaths, unfortunately, COVID is equaling these numbers and starting to get a little higher. But basically looking at the past couple influenza seasons, usually we see by now over 100 pediatric deaths, and there's only been one reported to the CDC so far this flu season. And so should masking be forever? I'll let you ponder that. And then I just like different health departments put out good graphs. So I liked this visual from the Minnesota Department of Health, where basically all these higher lines on both these graphs are influenza, and then down the bottom, which is basically the x-axis, is just this red. They've really had no positive flus, and that's really being seen across the country as well. And I definitely think, the masking recommendations, are masks going to be for longer? Would it be good to be wearing them during respiratory season all the time? They've definitely evolved as the pandemic progressed. Just looking back in February of last year, a tweet saying stop buying masks, that they're not helpful to prevent the general public. But this is based on what we knew about flu and the SARS outbreak in 2003, where it seemed like with the SARS outbreak in 2003, you got symptoms and then your viral load increased. Really with SARS-CoV-2, seeing that your viral load can be in your upper airway highest the day before in the first few days. And so definitely a different where masks can help. We found out that the asymptomatic, pre-symptomatic people are spreading. And so that just changed as things went on. And again, that higher nasopharyngeal viral load to where we kind of switched in April of last year. We should be wearing a cloth face covering, kind of wear it correctly. We, at that time, the CDC was recommending a 2-layer face mask, that they can't be used under the age of 2 on this infographic. But you should be using them. And at that point, people were using gaiters and maybe 1-layer things, but I think the CDC recently basically did a study where they found different ways that you can wear your mask that it fits tighter. And so wearing a mask that fits tightly to your face did a better job at limiting the spread of COVID-19. They did this by collecting potassium chloride that they sprayed out. So not actually viruses, and they used dummies to see these aerosols. And they found, which I've sort of been definitely seeing a lot of when I do the vaccine clinics, of people wearing basically a disposable, kind of our medical disposable mask, and wearing a cloth face covering over it. It's not recommended to wear 2 medical masks, so not 2 of our blue masks, because they're actually not, it doesn't flatten down. What you're really worried about, depending on the fit of your mask, is that there's often a little pocket, kind of, I don't know if you guys can see me here on the side, that kind of puffs out. And so it's really the cloth mask that helps that go down. So that's where the idea of the 2 masks. But then there's also this medical procedure where, procedure mask where they recommend knotting the ear loop and then tucking it in. And there is a video, which is down there if you wanted to look at that. I haven't felt compelled to do that. I do feel like I don't have as big of a gap. So depending on your face size, do you have a big gap on the side with your mask? There was one time months ago where I feel like we've had blue masks, we've had yellow masks, different masks. And there was one time where the mask seemed really large on my face that I did actually sort of I didn't do the ear tuck loop method, because I didn't really know that method. The ear loop and tuck, I just I did kind of tie my ear loops a little bit because the sides were coming out too far on my mask. And now, how is being vaccinated playing into this for me too, as well? Now that I have the vaccine, am I as worried that my mask puffs out a little bit on the side as or not? And then they talk about other options, putting a nylon covering over your mask and a mask fitter. I don't know if I haven't seen these. They had them in the article on I don't know, probably, where you can get a little kind of plastic thing to put over your mask as well. But if you wanted to look at how to do the knotted ear loop and tuck in the sides method, that link is down there. And so in closing, our winter and typical flu season's almost behind us. I think in the fall, there was a real concern we're going to have flu and COVID happening at the same time, having a lot of respiratory illness. And, with the interventions, the distancing and the masking we're doing, we're not seeing as much of that. There hasn't been a study yet either. People are noticing that absenteeism at work might be down, right? Because I'm not getting coughed at as much. I'm not, we're distancing, I'm wearing a mask. And so is absenteeism. Haven't seen it published yet, just rumors that companies and businesses that require people to be in person are seeing less absenteeism as well, probably from the masking. And that rigorous infection control continues to be crucial for protecting our healthcare workforce sort of in the coming months. And truthfully, in pediatrics, I think it's going to be true through next year. I mean, not everyone is going to decide to get vaccinated, which is a whole nother topic. But then in kids, they're not going to be able to get, not every 5-year-old is going to be getting vaccinated in the near future. And so how do we protect the kids, other kids in our waiting rooms? How do we protect people who have chosen not to get vaccinated? And again, there's always that risk with the variants. Is it going to make the vaccine efficacy a little less? So I think sort of these methods that we've been doing, we're going to keep doing. I had someone ask me the other day, when am I going to be able to see people smile again? And I feel like it's still going to be another year off before are we going to see people smiling at work again. In our upcoming sessions, we're going to focus on scenarios around PPE triage scenarios. So I think I'll do a few more scenarios just of people coming into the office and then they have symptoms, or there's COVID in the household. When can someone come into the office? And then do more of a general discussion, of briefly, like what do we do contact precautions for? What do we do this for? Not only sort of focusing on COVID. These are some of the resources that were used for this talk, definitely through the AAP. The COVID town halls have been helpful, really watching those. There's some practice management tips. How do you deal with it again, even if I'm not getting as sick at work, a lot of offices are having issues with staffing, right? Because your kid is sent home on quarantine and you can't leave them, you can't leave your kid home alone. And so there's definitely some staffing things that offices have had to think about. And I think that's going to keep for another year as well. There is something on the AAP site where there's a discounts for PPE and COVID supplies as well for that smaller offices can maybe take advantage of. And then links to CDC site and Project First Line. Some additional references that are just mentioned in the talk. And I really want to thank the main AAP and especially Dee Carey for inviting me to speak. And Dee also sort of directed me to these resources, which is basically where most of these slides came from, through the AAP and their kind of infection prevention echoes and CDC Project First Line. Sort of open it up to questions or anything that tips people have done during their office this year that they thought worked well. And if no questions right now, you can always, I just wanted to put my email up here. So if you want to email me any questions, that would be great too.
Wow, thank you so much. And actually I have a question to start off with. There was a question about using the infrared thermometers when people are coming from outdoors in the winter to scan people for temperatures. What are your thoughts about that?
I actually don't really like the idea of temperature screening in general. I think it gets you too close to people. Someone should really be able to tell you if they have a fever of 101. When that thermometer reads 99 or 100, what does that even mean? There's some evidence from studies in college-aged athletes that it's normal for a lot of us to get up to 100 degrees every afternoon with normal diurnal variation. And so I'm not a big fan of the temperature checks in general. But if you're going to do them, yeah, that's the hard thing. Or you're running in and it's hot in summertime and you put that on and it reads high, but is it really high? I sometimes recommend it, if it seems weird, then checking it on yourself as well. And so I don't really recommend the temperature checks, but I know a lot of offices are doing them. I went to the dentist the other day with my son, and tiny vestibule room, like, I don't know, maybe like very tiny vestibule, and the person checked his temperature, then checked my temperature. So I had to get really close to both of us. I mean, we were all masked, and said to me, "Oh, this hasn't been working on adults today." So I had no temperature. And my son, he had a regular, I think his temperature was like 96. So I'm like, that's not even working. So I don't know. I'm not as big of a fan of the temperature checks, actually. I think it makes you get too close to people and causes a bottleneck.
Great.
But some people do tell me, someone who uses them all the time can get skilled at them and get accurate temperatures.
I'm going to scan the chat box here.
Are we allowed to if we talk, can you guys hear us?
I can hear you now. Yeah.
Okay. Hey, I just wanted to say thank you for this. It was, I know it's not easy to give a talk with slides that aren't yours, but I thought you did such a great job of using the information on the slides, but also some of our local data. And I also thought, even though I think we've all heard a lot of what you spoke about, like having it collated into one talk and like getting rid of all of the things that sort of came along, but then were dismissed, was super useful. So I just wanted you to hear that this was a very useful talk. I don't know if you felt like you were just sort of saying things that we would all know or had experienced ourselves. It really wasn't that. This was super, super helpful. And I just wanted to say, I thought you did such a great job of like being dynamic about it, even though the slides weren't your own. I know you were kind of constrained in what you were.
Well, I had the option to make them my own.
Well, I thought you did.
I had the option to make them my own.
Okay. Well,
I did have the option. I could have completely changed them if I wanted to.
I don't think that was like, I think it was,
but thank you.
Yeah, it was a great mix of all of it. I just wanted you to hear that, because I didn't, I think a lot of us didn't quite know what to expect. And we were like, well, you just put on your PPE and that's it. But this was so much more than that. So I just wanted to say thank you.
Thank you. No, and I did think when I was like, oh, COVID talk a year into it about infection control, where everyone's been living this for a year and people have gone through cycles of what to do. I mean, I think everyone's sort of an expert in this now because every office had to do it. But it was even a little fun, like I said in the beginning, fun for me to, not fun, but yeah, no, kind of fun for me to review it and think about what has changed over the past year. Not necessarily fun, more like cathartic to think of where we are now compared to what we were a year ago, actually.
Yeah, I think when we look back on this, I think Wendy Davis said it in the chat box, was like the historical perspective on how this happened, just because of the pure need of like our what we had to do and how things changed, and what the way we had to come together as a community is going to be a pretty remarkable thing. And this was a great talk. I really appreciate it. I'm glad I came tonight.
Well, thanks for everyone for listening. And again, yeah, if there's any questions, feel free to email me. And I do like hearing about what people have done in their own offices, because the wintertime things that I've heard have just been sort of extraordinary to me, of how people were figuring out how they're going to see kids, even though they couldn't see him in the office, like seeing him in the car, seeing him in the parking lot, putting up tents over a few parking lot spots. I just think some of that is amazing. Oh wait, can I see?
Yeah, and Amanda, I'm going to say, I'm going to check the chat box and say thank you. And I'm going to echo what Jen said and say thank you that this really was helpful, and say when you're moving really fast as people have been to adopt change, that sometimes you normalize some of this and you just say, okay, yeah, we'll do it. But like this is also so important for creating that culture of safety and keeping everyone safe, the patient safe, ourselves safe. So reinforcing that and pausing for a moment to reflect back on where we were and how much we've learned, and to stop and think this is so critical to what we do, and keeping us all safe and letting us move forward and doing our jobs in a safe way. It is really important to pause and remind ourselves of all of this. So thank you. Really, thank you again. And I am just going to remind folks that this is recorded. It will be posted. And to encourage people, I'm going to go watch those videos now when I have a moment too. Those sound like there's some interesting little tidbits. Who knew about the double little ear twist, flip with the half twist, stick the landing? Sounds good. But I'm going to check those out. Those sound really really like there's probably some very good little tidbits to pick up there to keep ourselves safe. And I will say, please join us next week. We will be discussing vaccines, something that we're all very familiar with. We have a national expert coming in to talk about vaccines, vaccine hesitancy. We'll talk about the COVID vaccine in youth, and then just our regular vaccines that we are used to giving out all the time in pediatrics. So for folks that have stayed with us this evening, thank you again for spending the evening. It's 8 o'clock, and I do so appreciate people taking the time to spend the evening with us. And Amanda, thanks so much again for your time, and we'll see you again.
Thank you so much, Amanda. It was wonderful. Thanks, everyone.
Thanks. Have a good night.